So this is, I'm going to talk to you about why it's important in mental health to have an understanding of IPC, really. This is my experiences. That's all I'm sharing. And it's my experiences over the last nearly, just over 15 years of working in mental health. But please bear with me. Having a bit of an emotional day. Try not to cry. So this is me. I'm a mental health nurse by background, born and bred mental health nurse. If you cut my leg off, I've got mental health written through me like a stick of rock. Best way to think about it. For the eagle-eyed people amongst you, yes, I am wearing false nails on this photo. I had just finished a night shift in a prison where I'd been caring for some really poorly patients, and no, I didn't understand infection control. And I think I'll speak for all of us. We all have a moment in our careers where we go, oh, that's why it matters. And we shouldn't have that moment to understand why infection control is important, but that's what tends to happen to people. And that happened to me in 2009, had that moment of, oh God, this is where it becomes real. And infection control took over my career at that point. I was lucky enough to be able to go on and get my postgrad diploma, awarded in 2020. This was February. Never thought what would happen in March happened, but here we are, 4 years later. And this is the professional side of me, but this is the real me. I like to think I'm funny. I'm not 90% of the time, but I like to think that I am. I'm a lover of colourful tights, because not only do they prompt conversation, I think they tell a bit about me. And you'll probably sit there wondering, why is she wasting this time telling me about herself? There's a professional and personal side of me, and they intertwine. I'm here on a professional basis today, but I've got my funky green tights on. I'm going to try and be a little bit funny. We'll see how that lands. Because I can't turn these off. I'm always a nurse, and I will always think that I'm funny. And they go hand in hand together. And the same rules apply with this physical health and mental health. You can't have one without the other. You really can't. And you know that the minute that something happens, it will affect the other. So it's really important to understand that we have these professional and personal issues. We all have a mental health and a physical health. I am a service user by nature. Okay? I have a long-term physical health condition. I didn't ask for it. I don't want it. But it doesn't come with a gift receipt, so I can't give it back. But that has directly affected my mental health. And because of that, I suffer from anxiety. But my mental health is good at the moment. But actually, when my physical health gets bad, the first thing that hits the floor is my mental health. And if my mental health gets bad, my physical health gets affected too. Okay? Because there is no way of separating them out. Okay? And we all have these little internal monologues that go along when something's not going right. Okay? And yes, I am one of the 7 people in this, one of 6 now, where we all have a diagnosable mental health condition. That's a lot of us in this room. Okay? And that's nothing to be ashamed of. When I first started my nursing, there was a huge amount of stigma around medical professionals having mental health problems as well. You know what? It comes with a job. Unfortunately, new evidence is now suggesting that a lot of healthcare workers are being diagnosed with PTSD as an outcome of COVID. Okay? We need to start learning to live with it. And we know from research and evidence that there is too many suicides still. I never thought 20 years later I'd still be saying there's too many suicides. There are. We need to talk about mental health a lot more than we do. And anxiety and depression are the most common ones in England and in Britain. And we know that uptake of treatment is poor. It took me 7 years to get treatment for my anxiety, and I worked in mental health. So we know that that uptake of treatment is poor. And the new data that's coming out is suggesting that actually we're seeing a bigger increase now in people being diagnosed with these common mental health disorders as they fall out of COVID, which is something that we're going to have to accept and adopt as we move forward. So how does mental health affect our physical health, though, and why do they go hand in hand together? So we know that people with a diagnosable mental health problem have preventable physical health conditions, okay? Things like heart disease, okay? But there's a huge number of reasons for that, okay? Low motivation. People with mental health problems aren't motivated, okay? If any of you have ever had anxiety and depression, your level of motivation is through the floor, okay? It's really difficult to concentrate and plan and do anything. But also there's this diagnostic overshadowing that happens. And that is that people with diagnosable mental health problems often have it assumed that it is their mental health problem that's causing their physical health problem. And unfortunately, in the trust that I work with at the moment, we've had experiences of that lately, which is really scary, that someone who actually had a stroke was assumed to be drunk and just off their mental health meds. And that is terrifying that in 2024 that's still happening. Okay? There are these physical correlations. We also know that what we do in mental health services is we give people antipsychotics, we give them antidepressants, and what that does is it has an impact on people's immunity. So we are making them more vulnerable. In mental health services, we also put people together, large amounts of people. Some of our wards are 17 beds. We expect 17 people to all live together with their microbes all liking each other. Doesn't happen. Okay, they don't like each other, let alone anything else. And we wonder why people get poorly. And it shouldn't be a shock to us, especially as infection prevention specialists, why the wards that we have and the situations that we have drive infection. We know that if we get something in one of our wards, it's not going to remain with that one person. And we prepare for that worst case scenario. Anything better than that is great. Okay. So let's talk depression. So one of the most common ones in Britain at the moment, okay? This is what it feels like. If anyone's been depressed, I think you might agree with me on this, okay? But what does it actually look like to someone else, though? It looks like this. Tiredness, sleep problems, a bit of constipation. That could be anything, couldn't it? Yeah, we've all probably slept. I didn't sleep very well last night through fear of being here, but doesn't mean I'm depressed. But what it feels like to someone will look very different from the outside to other people. And the same with anxiety. If we take anxiety, okay, this panic, this on edge, the avoidance of areas, this fear, and it is a constant fear that weighs down on you that something's going to be really bad. But actually it looks really different. Yeah, people tend to be withdrawn, a bit restless, okay? Shortness of breath. I've just said to my colleague at the back, oh my God, my chest feels really heavy. And it does feel really heavy because my anxiety is making me feel like that, okay? But again, how many people probably feel like that in a day? You've really got to understand the difference between what the effects that it has on people. But also, if you know you've got someone with anxiety, these are the things you need to look for, that it's getting bad for them. But why does it matter? Why does it matter to understand any of that in our world that we work in? And it's because of these. We all know these, don't we? Yeah, I'm not going to cover them. Oh, good. It's always good. You're always off to a start when your IPC crowd know what these are. Okay? But these have a massive impact. And these are the things that we go to as our Bible, don't we? This is our Bible. Something happens, we look at our standard precautions, what we're going to do. All right? But patient placement. Let's think about patient placement for a while. If a patient is symptomatic with a potential infection, what do? We stick them in a side room and isolate, don't we? Lovely, in you go, let's shut the door. Okay? Patient has an infection, what do? Put them in a side room and shut the door. There's going to be a bit of a theme to this slide. Patients at risk, yeah, they might be neutropenic. Yeah, the clozapine might not be going well for them. Okay? Put them in a side room and isolate them, don't we? Okay? Or if they're at risk, yeah, because we know, oh, you've been exposed to something, oh, we need to monitor you. We pop you in that side room and we shut the door. Okay? What's going to happen? This is going to happen, isn't it? Yeah? Oh my God, what is wrong with me? Yeah? Because we need to appreciate those staff may not actually be fully aware of why they're isolating someone. That person's going to go, oh, okay, it's a bit lonely in here, isn't it? Because what happens is, oh, we'll put them on 15-minute OBS. 15-minute obs comes along, someone wanders along, they peer through the little hole in the door and go, "You're right." And the person goes, yeah, I'm fine, yeah, fine. But actually inside, this is what's happening and what it's going to look like. Yeah? Bit of a similar line to what it is to feel like depressed. If you've got someone with depression already and you're going to put them in a side room and isolate them, we need to be prepared for what the outcome of that might be. Okay? Personal protective equipment. I never found this funny. I don't know about those of you in the room, but actually during the pandemic I found this quite traumatic. My dad is hard of hearing. The minute you put a mask on, oh my God. He turns his hearing aids off at the best of times, but it just made things worse. And it's really scary. If you've got someone already in isolation that's fearing the worst because they're not sure quite yet what's wrong with them because we're pending test results, and then we're going in and we're going to be wearing all our PPE because, again, we're not quite sure what's wrong with them, okay? It's quite a scary thing. Communication issues comes into play. 1 in 7 have a hearing impairment. That's probably about 1 in 4 in mental health, especially when you start to include the severe and enduring mental health problems in this. Those people who are hearing voices and having visual disturbances as well. Yeah, concentration and hearing goes. But you can't read anyone. I'm a mental health nurse. I like to look at someone and go, "Are you smiling at me? Are you not smiling at me? What's going on?" And in these situations, you can't. You have no idea. And a lot of our mental health patients read body language too. They look at you and they go, what you're telling me, is that correlating to how you look? Because are you telling me something really good, but you look angry? That doesn't work, okay? So these body cues, this body language is really important. And the PPE just wiped all that out. It made it 100% worse for people, okay? And then we come along and give them complex information. So what we've done is we've popped you in a side room. We're not sure what's wrong with you, but there's something going on. We're going to wait test results. Every 15 minutes, we're going to pop along. We're going to have all our PPE on. You can't really hear us. You can't really see us. Okay, and then we're going to come along and go, "Oh, yeah, by the way, you've got an E. coli ASBL." And they're going to go, "Oh, yeah, great. What is that?" Because we come along and we give this complex information then. And diagnosis can be complex. Someone may not have one thing going on. They may have a multitude of things. And it's a lot of new information, okay? When we speak to our staff who are going to translate this information to our patients, they may not know what we're talking about, okay? Because they may never have looked after someone with it either. And it could be life-changing. If you're telling someone they're colonised with an MDRO, that's life-changing for them. Might not be at this point, but it might be in a few years' time. And we know that already their anxiety is going to be kicking in, their depression might be slightly getting worse, it's going to be a bit harder to retain that information. And then this old chestnut throws itself up, isn't it? Oh, we've got the 92-year-old that's confused. Oh, has she got a UTI? Have we considered that maybe she's just confused? She's 92. Is there some, or that actually she doesn't know where she is because no one's taken the time to tell her? Okay, is it that cause, is it that effect? And difficulty in making decisions. If I'm having a really bad day with my anxiety and you come to me with loads of complex information, I'm not going to be able to give you a rational answer. Okay? We need to apply the same to our patients. Okay? And then we wonder why they're not compliant. We sit there and we go, "Oh God, the person's coming out their room still. Oh, they shouldn't be coming out their room. We can't get them to stay in their room." Is it because actually they haven't retained that information? Why is it? Let's try and understand it. So what can we do about it? Because we've got to get our patients to comply. We've got to be able to get them to retain information. We've all got to work together because at the end of everything we do is one patient. Okay? And whatever happens with that patient may be different to the next one. So what can we do to make it easier? The first thing is get to know someone. I love going to speak to patients with, "Hi, my name's Lucy." It's a really simple thing, okay? Get to know people. Get to know your nursing staff, okay? What is your ward that you're going to about? In my organisation, we have mental health wards, we have community hospitals, we have hospices, okay? We need to understand what their purpose is. What type of patient are you getting? okay? Because that's going to change how we interact with individuals as IP professionals. Because when our approach has to be different. If we go and talk to someone in one of our hospices, the approach is going to be very different than if we go to someone in one of our psychiatric intensive care units. Okay? Our approaches have to be different. We have to get to know people. We have to understand what they are there for. This applies to your staff too. Get out and get to know your staff. We've all been there though, where you walk on a ward and someone runs away. Has anyone not experienced that? Because is that just me? Or they go, oh God, it's IPC. And that fear and dread comes in, okay? We need to embrace that as a, oh great, you know it's IPC. Lovely, thanks. Oh, by the way, I have a name. Get to know your staff, get to know what they're dealing with, because IPC is a very small part of what they do until they really need to do it. Listen to people. If a member of staff is saying to you, this patient is not going to isolate, you need to listen to that, okay? You can't then get upset and go, oh God, they're not isolating, if you've been told they're not going to do it in the first place. Think of an alternative strategy. Think outside the box, okay? We have a patient who would never isolate at all, but we have to think about differently. We have to think about, can we isolate you in an area? Yeah, he likes to wander. Have a bit of a wander, but in an area. Okay, let's give you some time out. Really listen to what people are telling you about your patients. Try and understand ways to adapt those standard precautions around them. Show a bit of compassion. Individuals with mental health problems didn't ask for them. They really didn't. And when they are in mental health services, they are in a crisis. They're not asking to be there. Okay? And they are not going out of their way to make your life difficult. Okay? They are genuinely having one of the most difficult times in their life. I see it as a privilege that I'm being allowed into their life at that lowest point, and that they're actually taking time out to talk to me, because they could just tell me to go away. And I feel really privileged and honoured to be able to be part of their life when they need that the most and they are at their worst. Okay? Yes, okay, it's not my sole job anymore, but I signed up as a nurse. Okay? And I'm a nurse through and through, regardless of whether that's infection control or if someone just needs a little bit of time out to talk and for someone to listen. Be kind. It's really simple. I get very upset when I hear, oh God, they're just being annoying, or oh, they're just being difficult, or oh, they're just trying to make my life difficult. They're generally not. I can guarantee you that they are not doing that, and it's really important. And think about, you are there for that one person. You are there for them. That is why we are employed. Okay, we are employed for that patient. And sometimes I believe that we lose sight of that. Okay, and we take it on board that we are there for us and we're not. We're there to understand them and what will work for them. Something that's not up here that I was thinking about quite a lot is about the language that we use as well, and how we need to tailor that to the individual. We're very equipped as nurses with great communication skills to be able to get people to understand. And it doesn't matter who you're going to talk to, you need to talk to them in a language that they will understand. And I know you've got John Otter on after me, but a couple of years ago he did a really good presentation about using the right language to be able to get people to understand what you want. And I think that is a lot about what we do. We are, as IP professionals, we are bombarded with really complex information a lot of the time, and we understand it and we digest it. That doesn't mean our nursing staff are, that doesn't mean our patients are, and we need to regurgitate that in a way that they will understand. And I think language is a real big issue. I know that if I was a patient, I'd want you to come to me with every single bit of information you had. I'd want it written, I'd want it verbal, okay? I'd probably want you to come back the next day just to confirm, and I'd want to see my lab reports that said I had that, because that's the sort of person that I am. Yeah, but if you went and talked to my dad, there's no point. There's no point talking at him. He isn't going to listen to you. He's probably got his hearing aids turned off. You're going to leave it in a written format, so in his time, he can read it. And I think that's something that we really need to think about, is that language. I just want to leave you with this. Mental health is just as important as physical health, okay? I can guarantee you two things. One is that 100% of my mental health patients have got a mental health problem, but 70% of yours have too, okay? If you don't work in mental health care, a huge proportion of yours have as well, okay? And you need to understand that, and you need to adopt and adapt skills for that patient, okay? Because you are the one that's in charge of their care at that point in time, okay? But also, if you think you're having a bad day, you're probably not having as much of a bad day as what your patient is, okay? But we are in a place where we can make that better for them, okay? My organisation, we go out and talk to our patients that are diagnosed with infections. That's quite a privilege for us that we have enough time to be able to do that, okay? But it also means we get time to talk to staff as well, because our staff are the ones that are going to be bombarded with those patient questions. Forming those relationships, listening to people, showing a bit of general compassion goes an absolutely long way in mental health. But please remember that there is no mental health without physical health and vice versa. And we need to give both of them the time that they deserve when it comes to our patients.